It is just a huge honor to podcast interview today the legend of endodontists in Arizona, Bill Leibow.
Hello.
How are you doing?
Fine, and you?
Oh, I'm doing so great. I'm so curious to know if you remember this, but I graduated in 87. I came out here, picked my location. It was May 20. I signed the lease. I graduated May 11, 87. Got open September 21, 87. And from May 11, 87 to September 21, 87, I was working at Sunshine Dental. Do you remember Sunshine
Remember
Dental?
those names.
And it was my first big molar root canal. And after about 3 hours, I had no idea what to do. And I called you and talked to your reception. She said, well, just send the patient over right now. And then anyway, then I called back and I said, well, can I talk to the endodontist? And you got on the phone and you retreated my first molar root canal. Do you remember that in 87? You'd have no idea. But you were so nice about it. You were so sweet. It was so bad. I completely botched it. I said, well, and I'm so dumb. I said, well, how did I do it? You could just hear you going, And so now it's so funny because that was 32 years ago. And so I still feel like I can feel a little bit about what it feels like to be that kid walking out of school, because the only real memory I have of my first endodontic nightmare was with you. So when I go to those dental schools, what I feel is sad is, there's 10 specialties, and you're an endodontist. That's
right.
one. But another one is public health. And when these kids walk out of school and they don't want to do molar endo, that cuts down public health access and availability. But I started talking to you because I'm such a fan of yours. I'm starstruck, but I need to read your intro first. Dr. Bill Leibow, DDS, MSD, graduated from Indiana University Dental School in 1974 and then went on to Boston University of Graduate Dentistry for his master's degree in endodontics in 76. He started private practice in Phoenix, Arizona that same year and was the 5th trained endodontist to start a practice in the state of Arizona. He began teaching as needed in 2003 at the Arizona School of Dentistry and Oral Health in Mesa, Arizona, with Jack Dillenberg, who we had on the show earlier. When the clinic opened in 2005, he closed his practice and went to work for endodontist Robert S. Rhoda, endodontist, who's been on the show, just an amazing guy, just a great guy, 2 days a week, and then taught in the dental clinic at ASDOH 3 days a week as co-director of endodontics, instructing students in the predoctoral endodontic clinic. In 2010, when one of his predoctoral students finished his residency in endodontics, he left the practice and became a full-time instructor at Arizona School, when he continues to teach to this day. He says he's going to teach until he can't hold a file. He is responsible for all the preclinical didactic education and co-directs with Dr. Gene Jasper and 4 other endodontists overseeing all the clinical endodontic treatment. Dr. Leibow enjoys spending time with his wife, Ellen, his 2 standard poodles, Roxy and Bailey, his Corvette, and photography. And I love the article you did. What's her name on up the street? Lisa Moeller.
Right.
There's another dental magazine right up the street, Lisa Moeller, class act lady, great magazine. And you did an article with her, top 10 favorites, and you knew your wife would read it because the first thing was your wife. So I figured either your wife wrote it or you knew Lisa was going to send her a copy. She says top 10 favorites were my wife, my standard poodles, my Corvette, my life, Arizona School of Dentistry and Oral Health, Dentsply Tulsa Dental Specialties for all they do, Vortex Blue Files, Brasler USA, Endo Sequence for pulp capping root repair, photography, designs for vision. Thanks so much for coming on the show.
Well, thank you for having me.
So how does endodontics look? How long have you been an endodontist?
Well, it'll be 43 years.
You said one of the things in Lisa Moeller's article, what is it called? Endodontic Magazine?
Endodontic Magazine.
Endodontic Magazine. You said Dentsply Tulsa Dental Specialties. And whenever
that's now Dentsply Sirona.
Okay, you're right.
Okay. They changed their name.
They got married.
They got
Is it
married.
one word or two?
Dentsply, I think I don't know if they go by Dentsply is one word, and then Sirona
Is it?
it's probably a hyphen. And It's two
Oh,
companies.
they're not one of them hyphen marriages,
I
are
have
they?
no idea.
No, they're not.
But
They're
a
two
good
words.
They're a good brand.
Good thing. Well, when I think of Tulsa Dental Park, who's the guy who founded that?
Ben Johnson.
And he sent Brad Gettleman, who wrote Chapter 8 in Pathways to the Pulp by Stephen Cohen, and we were classmates. He bought the oldest endodontic film ever. Did you see that?
No, I did not.
It's the first film and it's 100 years old. And I'll pull it up or send it to you or whatever. And
love to see it.
And it was so funny because I remember getting out of school. That was one of the earliest arguments. They're like, well, if you need to do all that, then why do these silver points last? Because they got an A in finding all the canals, cleaning and shaping. And so who cares what they obturated with? But I got to show you that video. But anyway, who's the founder of Tulsa Dental?
Ben Johnson.
Ben Johnson. When I had another endodontic, it was in 87. I called him up and he had just started Tulsa because he's in Tulsa, Oklahoma.
Right.
And I was calling him up and he was explaining something. He goes, well, he goes, it'd be so, I could show you in 5 minutes if you were here. And I said, well, I'm in Phoenix. It's a 2-hour flight on Southwest Airlines for $100. He goes, well, fly down and I'll show you. And I said, oh, and then I said, well, what's the closest hotel to where your office is? He goes, just stay at my house. It'd be a lot easier. So I flew down there, spent the whole day with him. And here was this guy, just showing me everything. And I that's why I've always loved dentistry. There's so many people like you and Ben Johnson. So he gave me that film. And I said, well, can I post this on social media in Dentaltown? And he goes, sure. I mean, he paid a penny for it. But so how does endodontics look differently now than it did 40 years ago?
It's more sophisticated. It's still basically the same principles. You have to clean and shape. And you have to have a good obturation and a good seal. And those are the core principles. Rubber dam still is preeminent. A lot of people think they can use Mr. Thirsties, or there's a lot of suction devices out there. Isolite, yeah, that's the one. But that still is not standard of care in doing endodontics. You still need a rubber dam.
So you're saying you have to work under a rubber dam?
You have to work under a rubber dam.
And it's so easy because the first day I opened my practice, I took a rubber dam, I tacked it onto the ceiling right above me, and I've been underneath it for 32 years.
Absolutely. But surprisingly, I mean, as an offshoot to this, I work for the Board of Dental Examiners overseeing endodontic cases that the board gets, and a huge amount of them are done with no indication that there's a rubber dam.
So they took a working length film and you can't see a clamp.
You take you have to put it in your record. You have to say, I put a rubber dam on the tooth. If you don't put it in the record, it doesn't happen.
So do they need to see a trial length film?
Well, because I can put a rubber dam on without a clamp. A lot of people can. But my notes always said there's a rubber dam on the tooth. And if my notes don't have x-rays of a file length for a trial file length, I have a notation that I did that with an electronic apex locator. So I know that it wasn't by feel, that there was a reason for me to have that length. I see cases all the time. There's no indication of how they achieved the length. There's no indication that they did a rubber dam. And that's the beginning of why they get to have a case against them for a poor root canal.
I never write on the chart that I've used a rubber dam, but I just don't use profanity.
Right.
That's just me. So it's still finding all the canals.
Finding the canals, knowing anatomy. You have to know the anatomy. My first associate in private practice was a microscope-trained endodontist. And almost every day in my practice, he would tap on my shoulder and say, I can't find the canals. And I virtually spent a lot of time learning tooth anatomy and thinking about tooth anatomy. I still think about tooth anatomy. And I would take 5 minutes to find the canal because I knew where to look. And that's half the battle. And that's what I teach the students at school.
Okay, let's I want to work backwards through this
Okay.
conversation because I mean I really feel like you were the fifth
Right.
endodontist in Arizona, and today there's the ADA launched a class action lawsuit against Delta Dental. Did you see that?
No, I did not.
And so let me find it for you, and it's all over Dental Town. Let me, because it serves the point I'm talking about. So let me go to the ADA website. The American Dental Association has filed a class action lawsuit against Delta Dental Plans and the Delta Dental Plan Association. The complaint alleges that Delta has engaged in anti-competitive conduct and violated federal antitrust laws by allocating territories of operation and dividing the national market in order to restrict competition and reduce reimbursement rates to dentists. The complaint goes on to allege that Delta's anti-competitive acts hurt both dentists and their patients by limiting the choices of dental care available to patients and making it more difficult for dentists to deliver the care the patients need and want. In addition to the ADA's complaint, individuals have filed several class action complaints against Delta, who alleging antitrust violations. In these complaints, the ADA and the individual dentists are requesting that the court certify the proceedings as a class action. The court will rule in the request. And what the one they're talking about is the suit against Washington by doctors Dentist Bradshaw, Todd Irwin, Nathan Russell, who talked about the lawsuit at length on show number 1164. And the bottom line is, I don't want to get into all that because nobody likes competition. I mean, the dentists, they wish that they could charge $1 million for a crown, do one every January 1st, and then lay off. And they're always mad that Delta won't do this and that. But how much insurance does the American Dental Association sell? None. And when Americans go buy $1,000 iPhone, do their employers pay for part of it? Do they want the government? So and it's supply and demand. It's checks and balances. The lion's not going to sleep with the lamb because the lamb knows the lion's going to eat it. And but that's not the point I wanted to bring up. The point is that Delta has more research on dentistry lasting,
Right.
and they'll never show it. I mean, when I go down to Chicago, the ADA's here, Delta's here. I go talk to the ADA chief economist, and they're like, no, they won't show me their data. They won't even return a phone call because of this type of relationship. But when I'm drinking with them at the bar, and I lectured to the insurance association, or anyway, there were about 100 dentists there that are the claims adjuster guys or whatever. They were showing me data that they would not post on Dental Town or let me publish in Dental Town magazine. That basically, when they look at hundreds of millions of claims that go back, as longer than your career, that when you do the molar root canal, in 5 years, 5% are extracted. And when I do it, 10% are extracted. So it's kind of like, I feel like no matter what all of us dentists are doing wrong, about 90% of them work.
Right.
So my question is, why do 5% of yours fail to need extracted, and why is 10% of mine? So is that 5%? So let's talk about...
that could be...
first of all, do those numbers, do they sound about right to you?
I never pay attention to those numbers. I know that the Endodontic Association, I know that molar root canal done by an endodontist predictably is probably about 5% greater success rate than a non-endodontist doing a root canal.
And that's what I just said.
Yeah, and that's what you said. And I would say that's probably...
And I just made that number up. It's just
no, that's probably reasonable. It's
reasonable.
They're complex teeth. And if you study anatomy, they're very complex teeth. The problem, I think, with general dentistry and doing endodontics is, number one, economics. Especially the kids coming out of school today are in such debt that they're doing everything. I think that's one reason. And some of it is the predoctoral education. Predoctoral educations in schools that have postgraduate programs do not share and do not give the predoctoral students enough practice to be marginally good at doing molar endodontics.
So do you have an endo program at AT still?
We do not have an endodontic.
Do you have any specialty programs? I know you got ortho.
We have ortho, and we have an AEGD program. And in our AEGD program, the endodontics is overseen by 2 endodontists.
And what about the other dental school in town?
They have 2 endodontists. Brad Gettleman works there, and Larry Johns works there. But all the endodontics in that school is overseen by general dentists.
But do they have an endo program there?
No.
And but Brad is amazing. So they got 2 endodontists for.
They oversee the endodontics in the clinics.
Just 2
when they're
guys,
asked, right?
2 guys for the whole school. Mm-hmm. When Brad and I were at University of Missouri, Kansas City, we had 6 endodontists.
Well, we have 2 full-time endodontists and 3 part-time endodontists at ASDO.
Do you remember ever hearing of an endodontist named Bambi Dur or Oguntepe?
No.
That was my favorite endodontist at UMKC. Just amazing. But anyway,
so it's education. I mean, when I have a kid leaving, I call them kids because I'm 72 years old.
You look great, though.
Thanks. When I have a student who leaves that school, they know what molars they could look at, and they know what molars they shouldn't try. We spend a lot of time educating them to be aware, to look at radiographs, to think before they jump, and they all leave with my cell phone number. Since that school has been open, they all leave with my cell phone number, and every month I get 2 or 3 calls and x-rays sent to me. Should I do this? Should I not do this? What am I doing wrong? Those kids have bought me for as long as I'm around and can answer questions. They all have my...
Well, you're only 72.
I'm only 72.
And your mother just passed...
At 101.
At 101.
Right.
Wow.
I don't think I'll be at school at 101. But so and then even the doctors that I remediate for the Board of Dental Examiners, because I do remediations, all have my cell phone number and are all free to call me anytime and ask me any questions, send me any x-ray, and I will help them. If they went through my class, if I've educated them, I'm theirs. And I don't charge for that afterwards. I think it's my duty.
You're so adorable. I mean, really. I mean, where does that come from?
I have no idea.
Your mom, probably, right?
Probably not. I don't know. It's just
probably
me.
Not.
It's just me.
Just you? Huh. That is amazing. You said so many things, I don't even know where to start.
Well,
but
the kids do molar endodontics from ASDO when they get out of school. They do them from Midwestern also. They're pretty well trained. There are schools, and I can't give you names, but there are students that I encounter, or some of my students will let me know that their associates have maybe shared a molar root canal in their predoctoral program, and that's their entire molar experience or endodontic experience. Well, you're going to have more failures.
You don't have to tell me the name of the
that.
school, but what city was it in?
I can't tell you.
Okay, just the state.
Just no.
I'm just kidding. Yeah, but do you agree though that that when we look at the specialty of public health, that having all the dentists being able to get someone out of pain, I always do the analogy of an emergency room. Imagine if you broke your leg and you went to the emergency room, they go, "Oh, we're sorry, we don't do legs, we just do arms." And I grew up in Kansas. I know how those farmers are. I mean, if you tell someone, well, you got to drive an hour and a half down Highway 51 to get to they're going to say, just pull it. Do you think that public health and endodontics, as far as availability, are kind of linked?
Probably a little bit. I'm not a public health bent individual.
Well, you got to get them out of pain.
You got to get the patient out of pain. So I think that because a lot of the ASDO students go to rural areas and work in FQHCs in rural areas and are in small towns, they need to know how to do molar endodontics. They need to know how to do a diagnosis, and they need to learn how to make somebody more comfortable to get them out of pain. and my students can do that.
So you got to explain what FQHC is for the
Federally
international.
qualified healthcare programs.
So if you're overseas, that's a explain what that is to someone from another country.
That's a program that takes care of indigent people, and it's government funded.
And when you say indigent people, is that just basically anyone from Mesa?
People from Mesa, right?
Okay.
No, there's a few of them. You know, I think St. Vincent de Paul may be a federally qualified healthcare program. There are a few of them around the city. I'm not familiar with all of them, but a lot of them offer programs. If the kids go and work for them for 5 years, they subsidize their educational costs.
But I want to hold your feet to the fire. Why do 5% of endodontist root canals fail? And then we'll go to...
I have cases that fail.
But what do you think it is?
Maybe anatomy. Maybe the tooth has got a crack in it that we can't see. More there than we can treat. The faster we do endodontics, the less time there are irritants like sodium hypochlorite in the canals, and the canals may not be as clean. I think predominantly, if it's not an anatomical issue, some endodontists do lousy root canals.
Really?
Oh, yeah.
So you think they do that because they're burned out, or
maybe greed.
Greed. Okay.
Got to do it too fast, make more money. I mean, I have to tell you, the greatest pleasure in my life was to retreat other endodontist root canals and have them be successful.
That was your
and my good friend Dr. Rhoda does that all the time.
Redoes other endodontist root canals?
Root canals from other endodontists or yeah. I mean, it's not common. With endodontists are better trained today with microscopes, and now we have CBCT scanners that they all have in their offices. It's easier for them to find canals. The technology has gone so far. It's how much money do you want to spend? I mean, you have all kinds of devices to help you.
Well, that's why this whole healthcare deal, it's hard for me to listen to it because, you know, I don't like to ever talk about religion, politics, sex, violence. But, you know, there's always this big old debate that, you know, healthcare should be free. And it's like, okay, so they don't even want to pay for their teeth. So they'll pay, their biggest expenditure is a house. Second biggest one is a car. Their damn iPhone's $1,000. And if their employer or the government doesn't want to pay for their root canal, they don't even care. So it's like, well, if you don't care, why, you know, you're going to send an IRS agent to confiscate my wages to buy you a root canal you don't even want?
People, you know, it's, you can't give stuff away for nothing, right?
Yeah, if they have no skin in the game.
They have no skin in the game. So my philosophy on that is if somebody had financial problems, I would help them with their root canal, but I wouldn't do it for free because there's no value to it if it's for free.
And I got my MBA while you were getting an endo degree. I got an MBA from ASU, and when I talked to those FQH people about the business, I said, well, what, you know, let's talk about the workflow problems, and I'll say, what is your number one problem? And they go, half of our appointments are no-shows. Right. They're no-show. So I go, okay, so how much is their copayment? Oh, well, we're not going to charge them a copayment. I mean, they act like that would be completely immoral. I'm like, well, who pays for their $10 a day pack of Marlboro Lights? Who pays for their $5 a day? You know, so they can buy a $10 pack of cigarettes for their own money, but it can't cost them $10 to make an appointment.
It's not a priority.
Yeah, so they have no skin in the game. It's kind of like but anyway, if they have no skin in the game, they don't care. So I want to go back to radiology because again, these kids come out $284,000 student loans on average. For all the kids, and that's all the kids with debt. That does not factor in, right, the kids who have no debt.
That's right.
That's how I understand that number. So is a CBCT standard of care? You're at the board.
Not yet.
You said yet, though.
Not yet.
Not yet.
Not yet.
Does that mean it's around the corner?
Well, it's coming down in price. You can pick up units for half of what they were selling for a few years ago. They're in the $50,000 range, I think. Now I just talked to somebody that was looking at one, I think in the 40-some thousand.
Do you know the name
range.
brand?
No.
Was it Korean?
I have no idea.
I know that they have come down for, but what would you say? So 40,000, is it a buy for you now?
For me, well, I'm not in private practice, so it's not a buy, but we have them at the school and we use it. Yesterday, we had a root canal that was done 5 years ago at school, and it's failing, and it looked great on a radiograph, see nothing wrong, and it was sore, and a CBCT showed a failing root system.
A failing root system, does that mean missed?
No, it's all filled. It looks really good. It's just not working, so next week I will go in and redo the root canal on that tooth.
Wow. So is it standard? So back to standard of care. You say it's not yet.
Not yet. Equipments aren't standard of care other than having a rubber dam on something.
Okay.
You know, a piece of equipment is using a rubber dam is a standard of care. Using a CBCT is not a standard of care. Taking diagnostic radiographs is a standard of care.
Equipment is not a standard of care. Taking diagnostic radiographs are.
Well, yeah, you have to have diagnostic radiographs, so the tool you use is not a standard of care, but allows you to achieve a standard of care.
Interesting, but you think now that CBCTs are down to 40,000. That
well, there are endodontists out there that use them on every case, and there's endodontists that use them only when necessary, maybe a retreatment or a difficult case, or they can't find a canal, or it's a radiographically very, very normal radiographs, very difficult case. They may take a CBCT. I mean, they're originally couched in the idea of this is if you pay this amount of money and everybody has a CBCT, then you'll make up the cost and you'll make more money from the CBCT. But that's not following the least amount of radiation acceptable ALERA rules. So you should only take something like that when you need it. It's more radiation than a PA.
Well, you know, when you take it on, when you said, you know, some people take it on every one, it reminds me of that. Did you see an article yesterday in the Wall Street Journal? Walter Reed failed to examine almost 2,000 CT scans. Oral pathologist Laura Ike, DDS, discovered nearly 2,000 scans went unread at Navy Advanced Dental School. It was it's all over. It was in Wall Street Journal, Military Times. So it sounds like when you have to when everything has to have a CBCT, the next thing you know, you might be reading about yourself in the Wall Street.
We have a radiologist at the school, board certified radiologist that reads the CBCTs and looks for other things. But the students come from this. I mean, I can only talk about my school, okay? Students come very well trained. They know what to look at. The radiology department works really hard with them, showing what you look for in cases. We had one student who graduated a few years ago, diagnosed coronary artery closing in a panorex on her father because she didn't just look for cavities and she just didn't look for his teeth. She was looking globally, and she found blockage in his coronary artery, probably saved him from having a stroke or dying. So the rule is if you take a CBCT, you either have to have a radiologist read it or know what you're looking at, or now you have limited field potential where you could take a 5 centimeter by 5 centimeter slice and only radiograph that with the CBCT. So it's a limited field. So you're not looking at the whole head. You're not looking at everything. And you can cut your liability by that.
So when it seems like whenever I talk to people like you and Rhoda and Gettleman, you know, it's successful endodontics is, you know, cleaning, shaping, and obturating is the least weighted. And then when you go drinking with non-endodontists, it's always how do you obturate. It's never finding all the canals, clean shaping. When we're talking about CBCT, is that more about finding the MB2, which it seems to me that that's the number one cause of a failed root canal? Because again, when I look at the insurance data, which tooth is the most likely to fail?
Maxillary first molars and
Yeah.
mandibular first bicuspids.
Yeah. So if you the first thing out of your mouth when we started this whole deal is know your anatomy. So do you think the number one most weighted reason to buy a CBCT is to find missed anatomy?
Well,
and thus you could do that if you actually are better with anatomy?
not necessarily missed anatomy, but why is something failing? Or you have a tooth that the when you look at a periapical radiograph, you can't see everything you need to see. The roots are very tiny. You can take a CBCT and see if there are canals present. You have a better idea of where you're going before you get there.
Better idea of where you're going before you get there. Huh, that is that's a fun way to put it. 5% of root canals fail because of cracks and irritants. We were starting
have cracks. You have pathology. You have complex cases. You misdiagnosis. Wasn't a root canal in the first place. Just poorly done root canals. There are a whole variety of reasons root canals fail, and even in endodontists' hands. I mean, they're very, very, very complex. If you look at the old studies and look at some of the anatomy that you've seen with, so I'm not really good with literature. If you look at some of the old endodontic literature, they show dye stainings of the complexities of the vascular system in a tooth. They're very difficult. And sometimes you can't clean it all. And the faster you do a root canal, the less you use hypochlorite. Hypochlorite digests dead tissue and helps clean the system. So knowing what you see and knowing what you read about endodontics, why would any root canal, because we do molars and we do lots of root canals at the school, why would you think any root canal would be successful in a predoctoral endodontic, in a predoctoral program in any dental school? Obviously, they don't have a 100% failure rate. We have a very low failure rate. I can't give you a percentage, but I haven't retreated very many teeth since I've been at the school. Why would you think root canals are successful in a predoctoral program?
Because if God's not on our side, whose side is he on?
No. How long does it take for an endodontist to do a root canal on average? 45 minutes to an hour and a half? How long does it take a dental student to do it? Maybe 2.5 or 3 hour visits, soaking in hypochlorite for all that time. The chemistry is cleaning the case.
Oh, I see where you're going with that. I wasn't even following you.
Time.
Wow.
So the faster you do a root canal, the more you need to adjunct materials to.
Okay, so do you remember a man by the name of M.L. Ryan, M.D., DDS?
No, I don't.
Here's the first root canal video ever done. I posted on YouTube. It's look at that.
Send this to me.
I'm gonna send it to you. And Brad Gettleman sent me that. That came from Tulsa Dental. Just amazing. But I never thought about that. That the young kids going slow because the bleach is doing all the work. That is so.
Does a tremendous amount of work.
That is so cool.
Yeah, so and then you add some ultrasonics to that, or some ultrasonics are just sonic activators that agitate it, and it gets better. So endodontists who are doing root canals at a quicker pace, some do, some don't. My favorite endodontist will remain unnamed. One of my favorite schedules mostly 2-hour visits for his patients. It's not about.
How come you won't say his name?
Because he didn't give me permission.
Is it because I'm sitting right here and you feel it's gonna embarrass me?
No.
Okay.
But
so I wanted to go back with that because I want to follow the money first because I remember how many times has there been some investigation in Congress and they say if you just follow the money you'll find it, There's another new piece of equipment besides the CBCT. They got a lot of student loans. It's called Sonendo.
Yes.
It's a chunk of change, and it seems to be more people are talking about the price of it than whether or not it's an actual buy. So I got the man on.
It's a mixed feeling between some endodontists love it, and they use it as a
explain to the kids what it is if they.
It's a device. I have not seen it work. It's a device that uses a technology. You have a specific part of its expense for each tooth. There's like a $50 expense. You have to put a special device on top of the tooth after you make access, and what it does is it allows the hypochlorite to flow through the canals and get into more spaces sonically, I guess. I don't know. I haven't really followed the technology.
So you haven't seen it yet.
I know about it. I have not seen it work. I've talked to people who've used it, and I've talked to people who haven't used it.
And any of your friends in Arizona using it?
I have a few that do, and I have a few that don't. And those that do swear by it, and those that don't, that doesn't make a difference. Their failure rate isn't that high. And though the history there's a lot of unknown studies yet to prove its actual validity, as far as what I've been told. There are a lot of if you read the journals, there are a lot of articles about it and its success, but there are a lot of articles about not using it with success.
But it's basically going to be.
This is like $55,000 and $50 a tooth.
And so let's talk about those two numbers. So you said the machine's basically $50,000.
I think it's somewhere in that range. That's what I heard.
Okay, and what's the difference between $50,000 and $50 a tooth? Because that's
$50 a tooth is you have to buy the guide that you use to put on the tooth is like $50.
But where I was going with that is this: it's $50 a tooth. I mean, $50,000 is a balance sheet number. Like a lot of people say, well, I don't know if I want to buy a CAD cam. It's $140,000. Well, first of all, no one gives them $140,000 for a CAD cam. When you look at the math, everybody that got it leased it. So now we're looking at $1,500 a month. So don't even discuss the $150,000 number if you're not going to give someone $150,000. So it's not a balance sheet number. It's a cash flow number. So it's $1,500 a month. So I'm asking you, if every month I gave you $1,500 for the use of other people's money for this CAD cam in my office, how do I get my $1,500 back? And you say, okay, well, it'll lower my lab bill because instead of to the lab, I'll do it right here. And I say, okay, well, there's a National Association of Accountants. There's Kane Waters. I mean, I can think of at least 3 different areas where I could go and get a huge big data set of numbers. And you're saying that all the people who paying $1,500 a month for a CAD cam have a lower Crown and Bridge lab bill. So it was a return on investment. And if you say yes, I know one thing. You didn't do your homework. You don't have an Excel spreadsheet. You don't have any numbers. You didn't read any of the math because you don't see it. So this on endo, it's 2 issues. It's $50,000. The thing I don't like about it is you're not going to give them $50,000. And you know why I know that? Because everyone that has $50,000, if you actually have $50,000, you won't spend it on anything. You know who buys a $50,000 new car? Someone who doesn't have $50,000, because now they just have to do a lease payment, $500 a month. People always ask me when young dentists get my car, they go, why don't you buy a new car? And I'm like, because this is paid for and I have cash. You have to be young and dumb to use other people's money for a car. So if you don't have $50,000, then I would say, well, then you absolutely, I'm going to post this video today of root canal. They've been doing root canals for a century without having to buy a $50,000 deal. And as far as $50 a tooth, wow, you just said something even amazing, that the younger kids have a high success rate because the bleach is in there longer. And I've noticed in my set of friends, the endodontists who are really amazing, They say that 30 years ago, they used to do 5 or 6 molars a day.
Right.
And now they're down to 4 or 3 molars a day.
Because we're seeing more difficult cases. Cases are, I don't know why they are. I think one thing about that is the general dentists today in some schools are getting better training and they're doing more easy. When I first started in endodontics in Phoenix, Arizona, I did central incisors, I did bicuspids, I did molars, I did easy teeth. The dentists just didn't want to do root canals. Today, students are trained better. There are more students doing the easy teeth, and therefore the endodontists are seeing much more difficult teeth.
Plus, today with dental therapists, aren't they allowed to do all the single canal root canals?
I have no idea.
I'm just teasing.
Yeah, in some states.
In some states.
But so we're seeing much more difficult. We're doing more retreatments. We're doing more complex cases. We refer probably 3 or 4 cases a week out of the school that are way too complex for general dentists to do.
And who do you send them to?
I make that decision.
Who do you send them to?
I send them to a couple endodontists in the valley who are also educators at the school.
Okay. So I want to tell you one of when I meet a dental epidemiologist, the thing that just is their trigger word that just really gets them upset is so many dentists after every root canal hears PenVK and Vicodin. Right. And the AAE has guidelines for antibiotics, but there's 211,000 Americans alive with a license to practice dentistry. 150,000 are 32 hours a week or more general dentists, 30,000, 32 hours a week or more with specialists. Of those 150,000 general dentists, 32 hours a week or more, how many of them do you think give a prescription for antibiotics after every root canal?
I would say probably 50%.
I know. So what do you think of them?
Well, I think it's stupid. If it's not every tooth needs an antibiotic. If it's a vital tooth, it doesn't need an antibiotic because it's vital. It's not infected. If it's infected and asymptomatic, it may not need an antibiotic. If they're infected and it's draining and there's pus and they're swollen, they may need an antibiotic to help them get through a crisis. I see patients come to the school that they've seen a dentist and they didn't like him, and I saw him in my practice, that patients come in, they got a tooth that's real sensitive to cold, and the dentist is too busy, so gives them pain medication and antibiotic and says, come back in a week. Well, they don't need antibiotics because their tooth isn't non-vital. It's not necrotic. It's not infected. Doesn't happen from the students at ASDO, as far as I know, because we pound that in their heads. And we very rarely give antibiotics, and we very rarely give narcotics at that school.
I know. That's why I quit going there.
Yeah, I'm sure.
So wait,
plenty do.
So if you did 100 root canals, how many would get antibiotics?
It depends on how many needed it.
But just for
you can't ask that question that way. Okay, so if you came to me and your face was swollen, and I started the root canal, but you had a lot of pus and I couldn't drain it, and you had an acute infection, I would probably give you an antibiotic. If you're very badly swollen, and I don't want to start giving you anesthesia in an area that's infected, and pass a needle through areas, I may put you on an antibiotic for 5 days to get your infection under control before I start your root canal.
And what antibiotic would you go with?
The drug of choice is amoxicillin. It used to be PenVK, but the drug of choice from the ADA and the AAE now for endodontic infections is amoxicillin. And if you're allergic to amoxicillin, it's clindamycin.
That's why, seriously, I'm not even kidding. That's why I always, when I order a pizza, always get mushrooms on it.
Always get mushrooms on it.
Because penicillin came from a fungi. Right. I think dentists should always have to eat mushrooms.
They used to use a narrower spectrum NVK, but now they're using a broader spectrum of amoxicillin.
So I'm just going to go from trigger words to trigger words to trigger words.
Yeah.
I know, the reason I hesitate to ask this question is because channel conflict is called when someone has to deal with people that are triangles, circles, and squares. Well, they don't want to come over here and badmouth the squares and triangles because they got to deal with them.
Right.
But on Dental Town, one of the biggest threads, and it's a huge thread, there's like 1,600 on it, is which file do you think is better for molar endo, Wave 1 Gold or Edge Endo X7? And before you even answer that, if I went to Tiger Woods, I know he could probably beat me in golf with any clubs from anybody. We always talk about, does size matter? Does the file matter?
That's a hard answer. I can't, I'm not familiar with Edge Endo. We use Dentsply, Sirona. We use Wave 1. We use Vortex Blue. Those are the two file systems we use at the school, plus a regular O2 taper hand file from Lexicon, which is a subsidiary company of Dentsply. Those files work great. Wave 1 Gold is great. Pro Taper Gold is great. I'm sure Edge Endo is great. I've heard pros and cons about it. I haven't experienced it. I don't allow the kids to have a lot of experience with different things because it's hard enough to get them to learn what they're doing with one system as opposed to giving them 2 or 3 systems. So they do a little bit of Wave 1. They do a little bit of carrier-based obturation. They do a little bit of everything in a narrow window. It's not the freedom like you have in a graduate program. Try this file and try this file and try this file. That's something that they need to research on their own when they get out of school. I won't comment on what file is better. Brasseler makes a good file system. They have 3 or 4 different types of systems. Dentsply has 3 or 4 types of systems. Edge Endo has something that they make that is comparable to 3 or 4 different systems, and there's just a whole variety of stuff out there. And I'm sure they're all good in somebody's hands.
Well said. It's funny how I look at all these different, because when you say, let me see, Edge Endo.
It's out of New Mexico.
Yeah, it's that's what I was just gonna say. When you say Edge Endo, I think of Chuck Goodis in New Mexico, and when you say Tulsa Dental, I only think of Ben Johnson. And when you say I like Brasseler Endo Sequence, because out of those 3 guys, Ben Johnson, Peter Brasseler, and Chuck Goodis, Peter Brasseler could drink anyone under the table, and he was a good old South Carolina boy, just an amazing man. But so
amazing company.
What's that?
It's an amazing company. They make a lot of good products.
What is it, Savannah, Georgia?
I have no idea.
It is, yeah, it is just amazing. But I really do miss Peter Brasseler. He was amazing. I talked about CBCT as a standard of care. Is loops standard of care when, of all the dental procedure? I mean, I really got to see the tooth when I'm doing a filling.
All the students at school are required to have loops to do their dentistry. I don't see it as a requirement to do endodontics, or a requirement. I mean, the ADA and the AE isn't going to tell you have to have loops.
Do you think you need, of all the 10 specialties, do you think you need loops more or less in endo?
More.
You need it more endo?
I need loops in a good light.
Do you use a miner's headlight, or do you use the overhead light?
I use a Brasseler 2-headed surgical operating light that is so bright it'll almost blind you.
That you wear on your head, or is on the ceiling?
I wear it on my head. It's not on my glasses. That's because I can have light and not wear my loops. I don't mean to be personal,
but I mean, obviously you wear a wig. Does it mess up your wig when you're...
No?
Nice.
My grandfather died with this hair.
Really?
So So no, we have microscopes. My light is brighter than the microscope light, and I use 4.5 or 6 loops. If I'm not using a microscope, I use 4.5 and 6 loops. I have a lot of friends that are endodontists that do 100% of their root canals under a microscope, and I have a lot of friends that are endodontists that after they make their initial access, they take a look at the floor and the chamber of the tooth with a higher power to see if there's any cracks or things they don't like, and then they go back to their headlight and their loops. Because it's just easier. If the patients are moving around, microscopes are hard to deal with. And so microscopes still aren't a standard of care to do endodontics. Even in graduate programs, they're all teaching microscopes, but the AAE hasn't said you have to have a microscope to do endodontics yet. And I doubt if they will. They would probably, the AAE would like states to come out and say molar endo should only be for endodontists. And there have been what's the word I want? There have been pushes from endodontists in the AAE to try to get that to be a standard of care. Endodontists only do molars. I don't think it'll ever happen.
Can we just kick them out of the country for asking, or do we have to tolerate their dissenting?
We have to tolerate them.
Yeah, of course they want to be the only ones that can do the root canal. There's 324 million people.
Right.
And why don't they just, wouldn't it be easier just to steal everyone's car?
That's right.
I mean, it's...
But it all goes down also, it all goes back to training. What are you comfortable with? I mean, I see a lot of endodontics for the board that's poorly done, mostly by general dentists, and I see some done by endodontists. And it's basically tincture of time, and it's quality of work and care. And you can be I have endodontist friends that brag about their 30-minute molars. Well, you can do a molar in 30 minutes. I have another friend who I said, Dr. Rhoda, who retreats a lot of 30-minute molar root canals by endodontists. I can't personally say what's right or what's wrong. What are you comfortable with? I mean, for me, a molar root canal in my private practice when I was doing it was 1.5 hours to 2 hours.
When I started with this interview, we talked about how dentistry's changed over the years. Was it mostly hand filing for you? When did it go from hand filing to rotary?
I can't tell you the exact date, but I can tell you that I was probably one of the last people in Phoenix, Arizona to start using rotaries, because there were a tremendous amount of them. The early rotaries, the sophistication wasn't there with the different heat-treated metals and stuff that you have today, and a lot of people left a lot of files in a lot of canals, and that's something that there was more stress and strain in my life to grab a rotary automated hand file than there was to sit there for a little bit extra time and go by hand. I was the torque motor. I was the torque system. It was my feeling. The instrumentation today is vastly superior. We use a motor that's, today you can buy a handpiece system that has been set up and programmed to do a specific company's files and stay within safe parameters.
Do you think that the fracturing has really dropped off?
I believe so. We have probably in the last 5 to 10 years at school, I think we've fractured maybe 5 or 6 files.
Because, Barry Musicant, another great man, he has his own system. And are you familiar with Barry Musicant?
No, I'm not.
He is he was the first dentist the first endodontist in New York City to be open 7 days a week. And he was just, he just thought that was important. So obviously he has the biggest, most successful office. But he started his own root canal system. It was called Essential Dental System, Safe Cider, stainless steel, going back
DDS.
and forth. So because they wouldn't break. And so that was a big solution to a big problem back in the day. But do you think files breaking today is much less a problem? Would you say it's gone the way of the dodo bird? And
Well, no, it still happens, but I think it's less. I will tell you, this is a personal thing on my part that you probably have not heard this. I don't know. Maybe not. It is not below the standard of care to separate a file as long as you tell the patient. It's below the standard of care to separate a file and not tell the patient. Now, you may not be able to get the file out, but you still aren't operating below the standard of care. What's going to happen one of these days is if you read the product sheets for endodontic files, the product sheets say they're single-use files. You're not supposed to sterilize them and reuse them. So some lawyer is going to say, call the office, do you re-sterilize your files and use them more than once in a patient? Yes. Well, you're not following the manufacturer's recommendation for that file system. So maybe there's a lawsuit there. I hate to say that on public.
That is...
But you're not following the manufacturer's recommendation. Single-use files, all the files in the school are single-use files. We do not sterilize and use them again in a patient. All the rotary files are single-use files.
But you're familiar with Barry Musakan's system, Safe Cider.
EDS, Safe Ciders. I've not used it, but I've read about it.
But you think that problem has gone away less?
I think the fracture of files is less than it used to be because the metallurgy is better. Is it all gone away? No. We still see files with separated teeth with separated files in them. The anatomy of the tooth. A file is not going to take a 90-degree bend if you're pushing it really hard and not separate. If you don't have proper access and you put more stress on a file, it could break and separate. So a lot of that has to do with how you shape the tooth and how you prepare the tooth for the root canal.
So another question they always get on this still is like, if you one step or two step, there's still a lot of people back to these 150,000 general dentists that are full-time 30 hours a week or more. How many of them believe that if you see anything periapical, cyst, anything periapical, you can't do it in one appointment?
Literature doesn't say that. Literature says that there are probably a lot of them that don't even read the literature and just do the root canal in one visit and give them antibiotics and pain medication, and the problem doesn't arise and goes away, which that's something else we talked about a little bit. The endodontic literature says that there's no long-term difference in the success rate of doing a root canal in one visit or two visits, as long as it's done right.
So there's nothing in the literature.
But we at the school do all necrotic cases in two visits, and because the kids are slow, most cases, even if they're not necrotic, unless they're single-rooted teeth and vital, do them one visit. But most teeth are done in two. In my private practice, I did all necrotic cases in two visits. When I would put calcium hydroxide in the tooth, let it sit in there for 3 or 4 days, help clean the system, and then have the patient back and operate. I never did necrotic cases in one visit. That's just a personal preference on my part. Literature says I can. I chose not to.
Are you friends with Ben Johnson of Tulsa?
We know each other.
I mean, is he a good friend or?
He's an acquaintance.
Okay, so you can talk bad about his product. What do you think about Thermofill?
I think Thermofill is probably one of the better systems if you know how to use it the right way. You didn't expect that, did you?
I did not expect that. I thought you were going to just piss Ben off right now.
I think that it's the most abused poorly done system out there because nobody follows the protocol, and that's why it fails. But if you follow the protocol and do it right, I think it's one of the better systems out there for obturating a canal. We teach it at the school, not in the clinic, but we teach it in the school in a sim lab experience because a lot of the federally qualified and where the students go to different community dental centers around the country, a lot of them use carrier-based obturation, and they needed to know how to do it the right way. I'm trying to get Dentsply and the school to put on a continuing education program with a particular endodontist from New York that is a master of carrier-based obturation and do a CE class in Phoenix on that because
who's that guy?
His name. I knew you were going to ask me that. I'll think about it in a minute.
Okay.
His name is Stephen Nimzik.
Stephen Nimzik.
Nimzik. He is the guru of carrier-based obturation as far as I'm concerned. I've learned a lot from watching him and listening to him and talking to him. And if any general dentist or endodontist that could take a class from Steve Nimzik would learn something.
And he's in New York City?
He's in New York, but he does lecture for Dentsply Sirona, and I'm trying to get him to come here.
So why... you really
it's just poorly done. It's
you really shocked me. I never thought I'd ever hear an endodontist saying like thermopil.
We don't teach it at ASDA. We teach it at ASDA, but we don't do it in the clinic. Number one, it's more expensive. It's more time consuming. You need to be pretty well practiced before you do it because it's so easy to wipe the gutta percha off of the carrier. So it's just more technique sensitive, but the students know how to do it, and one of these days we'll probably start doing it in the clinic.
So why do you like it though? Because
if it's done right, it creates with sealer. It creates a phenomenal seal if it's done right.
And
we do warm vertical condensation at the school, which is more difficult and time consuming. We use three-dimensional warm gutta percha because that's how I was taught. That's the system we use. So we get a very good seal when we're doing our endodontics, but I think that the carrier-based obturation gives you even a better seal.
So he likes carrier-based?
Oh, he does everything. He does all of his retreatments are carrier-based. He retreats a lot of carrier-based. He is a master at carrier-based obturation. Cleaning and shaping is... Cleaning and shaping, obturation, and particularly follow the tenets of how Ben Johnson sent that up to do it, and you'll get a good seal. But everybody cheats.
So you were saying that it's not very good because a lot of the people that take shortcuts are gonna.
That's why it fails is because people take shortcuts, and that's why endodontists hate it because all they got to do for several years and currently is retreat a lot of failed carrier-based obturation. I have yet to talk to a general dentist in the community who does it and ask him 2 or 3 questions and get the right answer.
So another change, and it's neat that you said Brasler, is when you and I got out of school, it was Grossman cement. That was the cement. And now a lot of people are switched to ceramics.
Right.
Where are you at on that?
I am not there yet because if you obturate a tooth with ceramics, calcium silicate cement-based sealers, and you fill short and you block the canal with the ceramic, you're not going to be able to get through and retreat it very easily. If the gutta percha goes through it, you can retreat it. But if you have a plug of calcium silicate cement, concrete, at the end of the root, not sealing real well, but it's very difficult to instrument through that stuff. You almost have to go in there with ultrasonics and a microscope to get through it.
So do you think that ethically we should be doing root canals so that they can be retreated? And that if you
I would like to be able to do one that I could retreat if I needed to for some reason, because maybe.
But would you say that
anatomy.
if the system was not retreatable, that would make this system not acceptable?
In my hands and my mind, yes. That's why we don't use it at school. But in other people's hands, it's a great system, and they seem to have a lot of success. And there's a lot of single point techniques out there that use that. So you shape the canal, you put your sealer in, and you just put a well-fitting single cone in it. You don't pack it at all.
So do you remember? You remember Joe Dovkin?
Yes, I remember. A good man.
Yeah, I was in
phenomenal endodontist.
Swanson Hall. We were on 9th floor for 3 years. I was 915 and he was 919. I think he's the smartest person I ever met, Dennis. I mean,
brilliant.
I mean, he could do. He was the only guy I knew that did all of his geometry and trig in his head. He said, "Well, you don't need paper." He was an amazing guy. But he, when it came to obturation, he was a squirter. He wanted the liquid stuff. Some people want single cone, somewhat lateral condensation. Well, what do you talk about Joey D's squirting? What do you think about hot gutta percha?
Well, we do use warm gutta percha, but we use a cone instead of squirting technique. And there are a couple. Joe Dovkin did it, and there's a couple others that I can't remember the names. John Stropko, I think, was a squirter.
That's right.
And John, they're both great. That you are a master at what you do when you're squirting, because it's easy to overfill and lose control of that.
So you're either a squirter. I would teach a
pre-doctoral
student. What's the other way? We
use warm vertical condensation with a cone.
But a squirter is one word. What's the one word for that versus squirter?
That's the only thing I've called them, that I've known that they've ever called them, is squirting.
Well, what did they call you? If you called them squirters, what did they call you?
Warm. I have no idea what they call.
Because the other thing, Joey D, always in his language was you were either an apical barbarian and always got a puff of sealer at the apex.
That's how I was taught by
or
Schilder.
You were
the Schilder technique.
The Schilder technique. So an apical barbarian or a pulp lover, and a lot of the apical barbarians didn't think much of the pulp lovers, and it was vice versa.
Everybody's different. But today in endodontics today, because of calcium silicates, because of MTA, because of Brasler biosequence, because of what's the other, biodentine. Those are all calcium silicates. They're very kind to pulp. Today we're doing a lot. As an endodontist, I look as an endodontist that part of my goal and requirement is also to teach the students vital pulp therapy. How do you preserve a pulp and maybe not do a root canal? So when I finished dental school and I finished endodontics, if you had a carious exposure, you did a root canal. Today, if we have a carious exposure, or some people are doing indirect pulp therapy before they do the exposure, and then they'll put some calcium hydroxide down to stimulate tertiary dentin formation. Then they'll go back a month later and clean that, let some residual affected dentin, not infected dentin, clean that away, and never do a root canal on a tooth. And sometimes that works. Or you have an exposure, you do a little bit of what they call a sphex pulpotomy, which is you go in with a diamond and you remove some of that inflamed pulp in the pulp chamber, and you put endosequence biodentine MTA over that and restore the tooth. And there's a good percentage of times, I won't tell you 50%, I'll say there's a good percentage of time that tooth will survive and never need a root canal. Never a guarantee, but it's always a try. The patients who read the video on why root canals are killing you, I can't remember the name of that video. You probably know it off the top of your head.
But I don't know off the top of my head, but
you know what I'm talking about.
Absolutely.
Okay. Root cause. They come to the clinic and say, I don't want a root canal because it's da-da-da-da-da. We can try vital pulp therapy, and if we win, they win big because they don't have to have a root canal. And if they lose, then they're no worse off. Their tooth is gone. I never try to sell a root canal to anybody, but I will try to sell treatment to maybe avoid a root canal if they're so opposed to it, or it may not need it. Depends on the symptoms of the tooth. It depends on the degree of exposure. It depends on a whole variety of factors. We do a lot of vital pulp therapy at Arizona School of Dentistry and Oral Health. A lot of people walk out of there that have had exposures and aren't getting root canals. That's the job of an endodontist also. Not just do a root canal, maybe avoid a root canal. Vital pulp therapy.
What did you think of the response to the movie Root Cause by your Association of Endodontists?
I thought they did as good as they could do it. It was a good response. I don't remember. I watched all of it and read all the stuff and all the responses. I personally, my point of view and my personal point of view is that I look at the patient and say, if that's how you feel, why are you in my office wasting my time? And then I walk out of the room and they go away and I don't even charge them for the day and my time. I don't want to have anything to do with them. And I will personally tell you that patient, if they change their mind, I won't do their root canal. Because if it goes wrong, it's my fault. So I refer them to other endodontists. I won't do it.
Well, when it comes to anti-vaxxers and the root cause, I mean, this whole country's on freedom of speech.
Right.
And when people want to argue with me, in my office, I say, look, what you really want to do is argue because can you give me the textbooks you read? Can you show me any data? Can you show me any work you're done? Well, of course you don't have any data. You haven't read anything. You haven't done any work. You want to argue, and I don't even call them anti-vaxxers. I call them the control group, and we need to have, in science, what do you have to have on a scientific experiment? So I'm glad that people don't get vaccinated and have their teeth pulled because we need a control group, and that's what they are.
I never argue with anybody who doesn't want to have a root canal for that reason.
Yeah, and the other thing that's crazy is pretty much, when people do 23andMe, I'll save you $100 right now. If you're thinking about doing 23andMe, you're related to mitochondrial Eve. She lived 50,000 years ago in Africa, and all 108 billion people are related to her. I do think it's romantic they called her Eve out of the Adam and Eve. I do. I think that's very romantic. Because, but anyway, 93% of all the humans are dead. I don't care if you don't get a vaccine or a root canal. I mean, if 93% of all humans are dead, I mean, you're alive, you're in the present, you're soon going to join the other 93%.
Well, yes.
Enjoy the ride on the rock.
Yes and no in that. So if you don't get vaccinated and you spread disease because you didn't get vaccinated, that's not a good thing.
But if the government forced everybody on Earth to be vaccinated, then it turned out that indeed something was wrong with it.
That's right. I
and
understand.
All the sapiens. Well, what happened? Oh, they went extinct because the government. The other thing I don't understand about the love for the government is when you look at the 5,000 years of recorded history, about 1% of all the people were killed by a family member, and 6% were killed by the government. So I'm always leery of the number one killer of humans forcing me to do something because to me, when you think the government should always have all this power and ruling and all that, to me, it just means that history wasn't one of your favorite lessons because...
look at polio, though. My bring this up, my first wife had polio and was in a leg brace. I mean, she was one of the last kids to have polio. But... look what that vaccine's done. Oh,
I know.
So,
but do you think it should be mandatory
for polio? Yeah.
What about the ones they're talking about today?
What are they talking about today?
Oh my gosh!
If there's a vaccine out there,
that you can't send your kids to public schools, unless they've taken all the vaccines.
Listen, and my kid comes home with something that he could have not had because the kid next to him, or if my kid's vaccinated, it's not going to happen. But maybe if there's another kid that's not vaccinated yet, maybe it's a poor family that can't afford a vaccination, and that kid gets some disease because some parent didn't want to vaccinate their kid, and that kid is now spreading that in the classroom. That's not a good thing. That's how I feel.
Yeah,
That's personally how I feel. I mean,
yeah.
I'm sure a lot of people will take exception to that. I don't like government telling me what to do, but I also don't want to have to worry about my kid going to school and coming home with a disease that he shouldn't have gotten.
Yeah, it's
a mixed bag.
So I want to. I can't believe we went well over an hour, and I know I should leave you alone. It's the Thanksgiving Eve. But another big debate on Dental Town that's always pops up for 20 years is do you refund a root canal when someone pays you $1,000? You do a root canal,
it fails,
and now it's in the trash can or it fails. Where does the refund? If you went to Walmart and bought something,
okay, so let's go a step beyond it. If you had a heart attack and you had a bad valve and they put in a valve. I'm going to talk about on a patient's perspective, okay? So you had a heart attack. You found out you needed a valve replacement. You had your valve replaced. You went to the hospital. You spent thousands and thousands of tens of thousands of dollars to get it done. And a year and a half later, that valve failed and they had to go in. Do they do that for free?
Hell no.
Hell no, right?
Right.
So why should I, if I did everything right and the tooth didn't work, why do the patients come and say to me, I want my money back, but they don't go to the hospital and they say, I don't want to pay for that? So there are instances where I'm in a dental school and a student does something inadvertently to destroy a tooth. Well, I'm going to eat that because that happens in learning all the time. In my private practice, I would go to the end of the earth, but if I did everything right, if you came into my office and demanded the money back, I wouldn't give it to you. But if I assessed you as a person that had not a lot of means and you spent a lot of money with me and now you're going to lose that tooth and maybe have to have an implant or a crown, I may give you your money back for that reason. But that's my choice, not their demand. I feel personally that if you did everything right, there's no reason to give the money back. If you did a crappy root canal, that's a different story. If you did a crappy crown, that's a different story. And when you want to get to that on an endodontic level, more endodontics fail because of crappy crowns than they do because of crappy root canals.
Okay, explain that.
Leaking crowns cause more endodontic failures than well-fitting crowns. If you do a poor restoration on a tooth after it's had a root canal and it leaks, it'll contaminate the root canal and root canals fail. More of the literature will show you, I can't quote who in the literature, but the literature will show you that more endodontics fail because of poor restorative procedures than they do because of poor endodontic procedures.
Yeah, and the other thing I always thought...
But back to your other thing, I don't believe if you did everything right that you should have to give the money back. That doesn't mean they're not going to demand it and they're going to ask for it or threaten you with a lawsuit. And if somebody came to me and said, I'm going to take you to the Board of Dental Examiners if you don't give me my money back, I would give them the address of the board on a card and said, well, here's where you have to send your complaint in. Be my guest. I've done nothing wrong.
That's
how I feel.
Yeah. That I do agree. That is
if you did everything right, you do not have people walking into their physician's office saying, my cancer came back. I want all my money back for my original cancer therapy. Right?
Right. But in those modern times, the new dean that replaced Jack Nullenberg,
he's wonderful.
Robert Tremblay is a dentist and an attorney.
Yes.
Does that say something about the timings when the dean of the dental school should really be a clinical dentist and an attorney?
I think he's just a brilliant man, and I don't know what his reasons for having both degrees were, but he's a phenomenal dean. Unbelievable dean. He's thoughtful. He thinks. He's considerate. He is very emotionally level. He's not up and down. He's calm. He's got the students and the school's best interest at heart. He gets who ASDO is, and he's been a pleasure since the day he's been at the school.
That's interesting how the first thing, one of the few things in describing him was he's not up and down.
Well, Jack,
Yeah.
was up and down. Jack is an emotional, I love him, but Jack is a different individual. He does a lot of good things. He's more emotionally up and down and passionate and not as level as Dr. Trombley is. That's not saying that that's a bad thing. That's just Jack's personality. It's been his personality as long as I've known him.
But it is more challenging in leading a team when someone's up and down.
Well, I think so sometimes.
Yeah.
We're waiting till the next best thing or what. We've just finished one thing and we're on to the next. And I love him because of his mind and how he thought and how he worked. Jack is just phenomenal. But Trombley is a different individual, and he's a phenomenal dean. They're both phenomenal deans. We wouldn't have the dental school if it wasn't for Jack and all of his passions.
Right.
I love them both.
Yeah.
They're both great people, but they operate different ways. But they both have a foundation of what's good for the school and how that school is run. Both of them feel the same way.
So do you feel as romantic to the American Association of Endodontists as you do Jack? I mean, it is the, like you talk about Rhoda. He's very big into
He's passionate
about the Arizona State Dental Association.
Right. I am not a member.
But you're not a member of the Arizona State Dental?
No, I'm not, because I am retired. Oh, you want to know why? Because I'm retired. I'm a full-time educator, and I would gladly give them a reduced fee, but they don't discriminate the fact that I'm an educator. I'm not in private practice. My income is significantly less. And they want to charge me, what, $1,000 for what? I will support them. I'll give them $300, $500, but they say no. That's an ADA thing, I guess. I have no idea.
I think I'm going to call this video. It'll save you the whole hour. It's an endodontist that likes Dermafill and is not a member of the Dental Society. Because that's what dental societies are. They're all filled with specialists trying to make relationships.
I'm a lifetime member of the ADA, and I'm a lifetime member of the AAE. The AAE, when I became a lifetime member and an educator, my dues went to nothing. I have to buy the journal and any other things that I want. When I became a lifetime member of the ADA, they at one time had a 50% subsidy. They made it a 25% subsidy that they will reduce your fee by, and then was told that if I don't continue that membership level, I'll lose my life membership. So older faculty in dental schools are running from the ADA. Some are, some aren't. I can't say in all schools, but they don't discriminate. And if somebody, I'm an educator, I'm at school full time, I'm not in private practice, I'm not making the money that I used to make. Have a consideration for an educator that's in a dental school on your dues.
Okay. One last thing. I can't believe we're at an hour and a half, but I'm looking at the endodontic boards, and it's amazing how there's some of these questions have been going on since the board started in 1999. But so it's confusing to a young dentist when you said, well, they say, well, why they go back to school, they're working with their mom or their dad. They say, well, why do you think that tooth died? And well, it has a crown on it, and when you put a crown on a tooth, a lot of them die. It's probably leaking. All that, so they say, okay, so probably leaking. So shouldn't we take the crown off, do a root canal, and make a new crown? And they send it to an endodontist, and you drill a hole through the top of it and do a root canal. So what if how do you know that it didn't die from leaking? And if it did die from leaking, wouldn't you have to redo the crown?
Yeah. Well, if you get inside the tooth and it's mushy underneath the crown, you know the crown's leaking. If there's decay underneath that crown, you know the crown's leaking. You can take good radiographs, and you can take explorers and see if radiographs and see if it's a well-seated crown. Once you're into that tooth, you can see a lot of. I've opened up crowns that were mush inside. So that crown I cut that crown off before I do the root canal, because if I don't, it's going to fail. I take out all the old amalgam. I used to take out all the old amalgam fillings, all the composites, put an ortho band around the tooth before I did the root canal on it so it wouldn't break, because the patient decided not to go back and get a crown. Or take it totally out of occlusion. Why did you do that to my tooth? This is a brand new crown. It's a different story, but I would take the tooth out of occlusion so they would have to go get a crown on it. It would totally out of occlusion if I didn't put a band on it. So that doesn't mean you have to cut off every crown that well-fitting before you do a root canal. You have to assess each case as it is. But there are a lot of crowns and fillings that you can take a radiograph of a brand new composite, and you can see that the margins are open. I'm not going to do a root canal on that until that's fixed, because it's going to leak, and then my root canal is going to fail. So I'll take that composite out and I'll restore it, and then I'll do my root canal.
Last question before you shoot me. I don't know if you brought a gun. He's from Arizona. He's probably packing a pistol.
Not today.
When I started this conversation, we started that right now, the day of this podcast, the American Dental Association is launching a class action lawsuit against Delta. This has been going on forever, right. And they there is checks and balance, supply and demand. They're never going to get along, because they're strategically they're different species. They have different roles. But because of that, we'll never get to see the data. And because we don't get to see the data, there's so many dentists who believe that amalgams cause more root canals for endodontists because it's expanding, contracting, and leaking, and that these composites were a godsend. But when I look at the data, I see amalgams lasting. There's so many studies that last 38 years, and there's so many studies on composites that they only last 6.5 years.
So if you had an MOD tomorrow, would you have an amalgam or a composite in your first molar?
Amalgam.
So would I.
Oh my gosh.
So now I'll ask you another question if you want to go on farther. Okay.
Yeah.
CEREC crowns. Latest innovation, all this good stuff. Do you have to have a chamfer? You can't have a chamfer with a CEREC crown. I think you have to have a butt joint, right?
Mm-hmm.
A millimeter and a half butt joint around the tooth.
Mm-hmm.
So what happens when you cut through that CEREC crown to do a root canal? What's holding that tooth on? The butt joint, because you just took all the axial walls away in accessing the tooth, right?
Mm-hmm.
If you made a large access, if you made a conservative access, you may not. So the worst case scenario was a young man who came to my office when they were first doing CEREC crowns. So I know they're better now and the cements are better. I did 14 conservative root canals on that young man, and he lost 14 crowns because the only thing that was holding them, the axial walls, were all gone because they were so over-prepped. So does that mean that every time you access a tooth that's got a 3D printed or a CAD-CAM crown that with butt joints, and you do a root canal on it, is that crown going to fall off? You can put a post in those, but post doesn't strengthen the tooth. It offers resistance for them, not retention. post will break, and the crown will still come off because there's nothing. Because I put post in those 14 teeth, and the crown still broke off because there was nothing to retain them. There was no chamfer, just a butt joint with resin cement. It's a whole new thing we're going to start seeing.
Whenever I hear the word post, it triggers one response. I have done podcasts in Tokyo, London, Paris, where the dentist told me that, well, the government only gives us $100 US for a molar root canal. So we have to put a post in every root because we'll pick up another $80.
That's just going to weaken the tooth even more.
But they can't do a root canal for $100.
Why? Just do more of them.
I mean,
I have no clue.
Yeah, I mean, you can. I mean, those are 3 high overhead places on the planet: Tokyo, Paris, and
majority
London.
of teeth that have root canals don't need posts and buildups if there's enough to get a ferrule. You need a ferrule for a crown to be retained very well if you're going to do a root canal.
So historical trivia, do you know where the ferrule came from?
Where?
Barrel making. The barrels kept popping, and they found out that just a little 2-inch ferrule around the barrel, they could stack those barrels 10 high.
Well,
so all that ferrule knowledge came from barrel making.
I'm not opposed to Cerac crowns. I'm not opposed to all that. I think it's great technology. I think it's going to be wonderful. But my concern is when I do a root canal on those teeth after they've been prepped, if they've been over-prepped, and I'm sure there are a lot of dentists out there that are probably going to over-prep and have bigger shoulders. And if those need root canals, are those crowns going to start falling off?
So final question, it's the eve of Thanksgiving. What are you most thankful for?
I'm most thankful that I have a wonderful wife, that we have a great life, and that my mother died peacefully.
At 101.
At 101.
And what are your final thoughts on Mom?
She was just a great lady. And I'll miss her. Although she didn't know who I was for the last year of her life, I'll still miss seeing her every Sunday.
And where was she born and raised, and where were you born and
South
raised?
Bend, Indiana.
No.
Buttigieg country.
So you're a Hoosier.
I'm a Hoosier.
Now, did Mom move out here, or how did you get from Indiana to here?
Mom moved here because she was in her 80s, I think, and she fell asleep at the wheel of her car and broke her foot. And we told her that we weren't going to run to Florida because she was living in Florida. They retired to Florida. So that we were not going to fly to Florida every time she had a problem. She had to move here. So she moved here.
And that's why they call Arizona the Florida of the West.
That's right.
And she
lived here for over 20, almost 20-some years.
And I'll just say on the final thought, we are the Florida of the West in every way. I mean, Florida and Arizona are just the same. But when I got out of school, my biggest diagnostic errors were with people that I thought weren't going to live much longer. And I thought, well, I'll just patch this tooth or this. I mean, this guy's old.
Can't do that.
Oh, my God. And it'd be like, and there he is, 20 years later, still coming in. And you just, my gosh, I mean, I don't even know if I'd patch teeth at 100. When would you quit doing definitive treatment on your mother?
My mother had very little treatment. She still had all of her teeth.
She what?
She still had all of her teeth.
Yeah.
She passed away.
But
I did not work on my mother unless she needed a root canal. She went to a general dentist that I sent her to, and she stayed with him until she went into the nursing home. And then she went into where she was in complete nursing care. Otherwise, she went regularly for her cleanings and stuff to the general dentist. I don't do dentistry on family. I learned that by doing root canals on my wife and having her wisdom tooth fail.
Huh.
So I can tell you that the first root canal I did on my wife was her third molar, and the first dry socket that I gave my wife was when I extracted that tooth. And that was the last time I worked on my wife. I did 2 other root canals on her, but I don't do dentistry on family.
Well, thank you. I'm so thankful that on the eve of Thanksgiving that you came down here
Thank you.
to Ahwatukee and let me podcast you. I will send you that video.
Please do.
I'll do it right now before I leave. Okay. And thank you. Shout out to Jack Dillenberg for arm twisting him to make the drive down here to Phoenix. Thank you so much for coming on the show.
Very
it was
welcome.
An honor.
Thank you.
And thank you for fixing my first failed root canal.
You're very welcome.
All right.
Thank you.